Good morning, everybody. Sorry, good afternoon. This is an unusual session for us in the afternoon. Um, this is the next webinar, the COVID-19 webinar on the topic COVID-19 and skin conditions in the workplace. And it is brought to you by the National Institute for Occupational Health, which is a specialized division of the National Health Laboratory Services and a sister division of the National Institute for Communicable Diseases. And we're delighted to bring you this particular webinar on COVID-19 and skin conditions in the workplace. And I'll be introducing the two contributors for today's webinar to you in a moment. Just a quick touching on the virtual house rules with regard to your communications with us. Unfortunately, the number of participants we expect in these sort of webinars is more than what we can allow for open microphones. We might assess that towards the end, depending on time availability. So please type all of your questions for the presenters related to the content of their presentations in the question and answer box. That's the double speech bubble, the two speech bubbles at the bottom, Q&A. That's where you click and you can type your questions there for the presenters. The single chat speech bubble, the single speech bubble is the chat box. That's for general administration and general questions and interaction, not for your questions. Please, if you type your questions there, we require you to copy and paste your questions into the Q&A box. That will be much appreciated. Our presenters will be answering your questions there. And if the presenters choose, there may be one or two questions they may want to clarify with you. And we will ask you then to assist with that clarification. And maybe then towards the end, the open microphone might be needed for one or two people. So all questions will be answered in the Q&A box. We do provide general certificates of attendance that will be circulated as soonest after the webinar. We are under current significant administrative pressure, so some tasks have been delayed, unfortunately. For those who require the CPD, the Continuous Professional Development Accreditation Certificates or attendance certificates, you'll be sent a link and a password for the online CPD test. And that is what you'd have to do in order to meet with the requirements, specifically and especially for the Health Professional Council of South Africa. With that bit of admin out of the way, as I've indicated, we've got two speakers, one on skin manifestation in patients with SARS-CoV-2 infection by Dr. Raboobee, who's a dermatologist in private practice. I'll be introducing him in a moment. And that's followed by a colleague here at the NIOH on skin reactions to COVID prevention measures, cleansing agents and PPE, and alternatives to reduce the impact. And that's by N Fourie, who's in the Immunology and Microbiology Section here at the Institute, the NIOH. And thereafter, we'll have the Q&A session. So without further delay, if I could just get to these notes. Okay, I would like to welcome and say thanks to Dr. Raboobee, who's a dermatologist in private practice for the past 32 years. He's president of the Vitiligo Society of South Africa, I hope I've pronounced that correctly, and executive committee member of the Dermatological Society of South Africa. He has done many presentations to general practitioners, dermatologists, and in congresses internationally. He has participated in publications in the Journal of American Academy of Dermatology on skin manifestations of COVID in South Africa. He's in private practice in Westville Hospital. And then finally, he's also a senior lecturer at the University of KwaZulu-Natal for 25 years until 2015. And with that short introduction, I welcome Dr. Raboobee. Thank you very much for joining us and making the time to prepare and share your information and slides with our participants. I hand over to you, sir, just to check on your audio.
Thank you very much for the kind introduction, Ashraf. And I'd like to also thank N Fourie for this invitation. Thank you very much. and also Tabania for helping with the presentation. So I'm going to share the screen and give me a second. Right, is that visible?
Yes, it is. And if you could just stay as close as possible to your microphone, that would be great. Please proceed. Thank you.
Right, so thank you very much once again. And this is the hospital I work in Westville Hospital. You know that I'm speaking from a very troubled Durban at the moment. Our hospital and certainly the practices are all closed in Durban right now. And we are not sure when we are going to be going back to work, but you've all been seeing the images on TV currently. So this is coupled with the COVID scenario. We have the unrest going on in Durban. So we're going to be chatting about the skin manifestations of COVID-19 infection. And I would also like to convey my condolences to friends and colleagues and families and the South African community in general, especially for those who have lost. And then how to keep our practices safe, which I'm sure a lot of us are doing at the moment, but it never harms to share some ideas. So we know that the first case of COVID was diagnosed in South Africa on the 5th of March 2020, and this was a 38-year-old male who went to Italy and returned on the 1st of March, and the rest of it is history. We are now currently in the grip of our third wave. We have over 2 million cases with over 65,000 deaths. And you can see the worldwide figures just below the figures on the right. And the map at the bottom shows the distribution as far as provinces are concerned. And the map on the left lower end of the screen shows the number of vaccinations that we've achieved to date. Just over 1 million have been fully vaccinated, 1.3 million, and 3.7 million have received at least one dose. So why are skin manifestations important in the first place? So we know that the skin can be the first or the only manifestation of COVID, of systemic disease. And skin manifestations are often important in identifying viral diseases. We know that chickenpox, for example, gets recognized because of its rash. So we also recognizing the signs of COVID may lead to early detection of the diagnosis of COVID and then better management of the condition. And skin features, we know now, play an important role in determining the prognosis of this condition. So we can divide the dermatological implications of COVID into these 4 main categories. In other words, the direct cutaneous manifestations of COVID. Hang on, this jumped. Then the cutaneous adverse reaction to COVID-19 medications, the skin changes from COVID-19 lifestyle alterations, the hand washing and the sanitizers, the masks and so on, and then the effect that COVID-19 and its therapy have on primary skin diseases and of course their management. Now the incidence of skin signs is very variable. For example, it is 0.2% in China, and in northern Italy is found to be as much as 20%. But the worldwide incidence is around 1 or 2%. We'll chat about chilblains, so we'll talk about its incidence later. Now this was the first publication of skin signs of COVID, and this appeared in the Journal of the European Academy of Dermatology on the 26th of March 2020, and this was by Recalcati et al. In Italy. So they reported on 148 patients, out of which they excluded 60 because there was a drug history, so they had finally 88 patients. Now, they found that most of them had an erythematous rash, and some of them had urticaria, and some had chickenpox-like vesicles. We'll have a look at examples of these as we go along. But this is just by way of introduction. You can see the numbers of the percentages of the patients that have had these conditions, and we'll have a look at them in greater detail. Now, this was a patient who presented with acute urticaria, a 51-year-old female, 3-day history of cough and arthralgia, and she had simultaneous onset of urticaria, although there was no angioedema. And this affected the trunk and the limbs, and it responded to loratadine. The treatment of the urticaria, of course, would be just like treatment of urticaria generally, but we need to consider the possibility of COVID when one sees urticaria in practice. This was a patient from Tigerberg Hospital, a COVID positive patient that was submitted by Dr. Fisser, a 50-year-old male who presented with urticaria, quite extensive, but COVID positive. And another COVID positive submitted by Dr. Lucien Pillay from Johannesburg. Now, at the time that we were looking at skin manifestations, we had actually sent a questionnaire out to all the dermatologists in the country to let us know how many of them had actually seen skin manifestations of COVID, and if possible, to supply their photos. Remember that it wasn't always possible to take photos. In those days, it was sometimes difficult to carry cameras into ICUs and so on. So some of the times there were no photographs. But these were pictures submitted by the dermatologists around the country. We were not directly involved in seeing COVID patients, and we didn't have the luxury of seeing these rashes ourselves, but I thought I'd share them with you so you can see how they manifest. Now, these are chickenpox-like vesicles, and this was reported in the American Academy Journal, and they had a multi-center case series of 22 patients presenting like this. And here's another example of varicilliform like chickenpox-like vesicles. You can see them quite clearly in different stages of evolution. They don't always look like this in different stages. Sometimes they can be pretty monomorphic. So here's an article by Schwartz, and he's on the extreme left of this picture. He came as an invited guest of the Dermatology Society and of the Vitiligo Society, and he actually published this paper on chickenpox-like vesicles in patients with COVID-19. And that last picture you had seen was from that article. Now, this was a patient who presented with herpes zoster-like vesicles, an 80-year-old female who had COVID-19, and all 5 members of her household were infected. Although her presentation was with weakness and pain, and she was admitted to ICU even, she presented with these hemorrhagic vesicles on the legs. But she responded to Zelitrex and prednisone. This was sent by Professor Abubakar. And now the COVID toes has received a lot of media attention. In fact, this is one of the first conditions that actually made the rounds on social media, COVID toes. And this was called acroischemia medically. It was also called pseudochilblains and pseudopernio. And now it is generally known by the name pseudochilblains because it resembles chilblains. And chilblains is where you have erythema of the fingers and toes, and it may skip some toes, but it can progress to vesicles and ulceration and sometimes purpuric looking lesions. And this is the same patient after a few days developing blisters and developing ulceration. But this carries a favorable prognosis. It heals up usually. And the first case was reported in Italy in February 2020. And this was seen mainly in children and adolescents. The hands and feet were involved. And as I mentioned, not all fingers and toes, but sometimes they were separated by unaffected digits. And if the entire finger was involved, you'd see a clear line of demarcation at the metatarsophalangeal joint. And they can present with reddish purplish or bluish and then bullous and even blackish crusts. They can be painful when they develop, but they resolve usually over a 2-week period. And some more examples of chilblains. Now, when we collected these cases, it was in July last year, we had many submissions from Johannesburg, and we had only one from Durban. And we know that Johannesburg winters are extremely cold, and chilblains is something that happens in very cold weather. So this is something we needed to bear in mind. And it wasn't very clear at that time whether this was happening because of the cold weather or because there was an actual association with COVID. But generally, it is now accepted that this is a COVID manifestation. Not all these patients could have COVID tests done, but many of them had confirmed COVID tests. There's another example of the pseudochilblains or COVID toes, and further examples. Some of them are erythematous, not all toes are involved. They can be blisters. They sometimes become blackish in color. And another example from Johannesburg. So one needs to take a history of cold exposure and a history of Raynaud's in such instances, but one also needs to investigate the coagulation profile of the individual and to look for cryoglobulins, and swabs have now become necessary in such patients. And this is pseudochilblains of the fingers. If you are interested in reading more about this particular manifestation of COVID, then I would like to refer you to this article by Esther Freeman et al. And this is Pernio-like skin lesions associated with COVID-19. And this was a case series of 318 patients from 8 countries. So the association is now well established. Now, another manifestation of COVID can be livido reticularis. And this looks like a network pattern of enlargement of the circulation of the blood vessels. And the blood fills in these vessels. It's not actually bleeding into the skin. So these are non-pruritic, they blanch and they're vascular. They're transient. They disappear within 24 hours. And this particular patient was COVID positive. And here another example of livido. So you can see the network pattern. It's transient. It's blood flowing within the blood vessels, but not leaking out of the blood vessels. And then petechiae is where the blood is actually leaking out of the blood vessels. Now the first patient that was reported with this petechial manifestation was in Thailand. And the authors thought that this patient had dengue fever and investigated the patient as such until the patient was admitted for respiratory problems and then was found to be COVID positive. Now, when these articles were published, I had drawn up this poster for our doctors and people who are seeing patients at outpatient departments and so on. And I would be very happy to share these posters with you. The first one was made after the first publication, and then there was another major publication with new skin manifestations. I made another poster. And if anyone would like a copy of this, then please send me an email. The email address is written at the bottom. And please feel free to send an email and request this, and I'd be happy to send this over to you for your clinic, for your practice, or just to have a look at. I'll show this again a little later on if any of you have missed it. And then there was another major publication. This was a classification of cutaneous manifestations of COVID-19. And this was a sort of case series of 375 cases that came from Spain. So here they classified the skin manifestations into 5 groups. And that was pseudochilblains, vesicular lesions, urticarial lesions, maculopapular eruptions, and livido or necrosis. And they found that almost all patients who presented with skin manifestations of COVID could be classified into one of these categories. Now also at this time, they found that there was a temporal association between the skin lesions, the onset of symptoms, and the severity of the disease. Now previously, we didn't have any idea that there was any association with severity or with prognosis. And now for the first time, we began to understand that there was in fact an association with prognosis. So vesicular lesions appeared early. The ones that I showed that looked like chickenpox happened early in the course or in the evolution of the condition. However, chilblains, the pseudochilblains, occurred late after the other symptoms. And generally, it was associated with less severe pulmonary disease. So we could even begin to prognosticate with these skin features. And livido reticularis was associated with very severe pulmonary symptoms and ICU admission. Then came descriptions of other diseases like pityriasis rosea. Now, pityriasis rosea, of course, can occur even without COVID. And this is considered to be a herpes virus infection. But there were many reports of pityriasis rosea being triggered off by COVID. And this is another example of atypical pityriasis rosea. And we know that pityriasis rosea presents with a single herald patch. And after a few days, you get a Christmas tree-like eruption on the back. And the condition would be treated like we normally treat pityriasis rosea. This is an example of a patient with pityriasis rosea that I treated in my own practice, but this patient wasn't COVID positive, it was pre-COVID. And this was a response to narrowband ultraviolet B light. And within a few sessions of treatment, we managed to suppress this completely. And this can be offered also to patients who are positive. except one would exercise all the precautions when treating positive patients. Now, this is a morbilliform eruption, and we know that morbilliform means measles-like. Morbili is measles, and the differential diagnosis for this would include drug eruptions. We'd have to think about viral infections, measles, mumps, infectious mononucleosis, Coxsackie, all come into the differential diagnosis, and they can look exactly like this. We see it, for example, sometimes when we use Perbac for acne, once in 5 years or so, patients present with this kind of an eruption. And here's a COVID positive patient who presented with a morbilliform eruption. So this can be quite extensive, and it looks red, and it looks sometimes a little bit follicular, but these are not actually follicular lesions. Now this is erythema multiforme-like lesions, and you know that erythema multiforme would be target lesions, and this can be a presenting manifestation of COVID. And here again we have pityriasis, the erythema multiforme rather, and you can see that some of them are actually target lesions. Here another erythema multiforme. This was from Tigerberg Hospital. The patient presented with fever. It was a 13-year-old male, and presented to the emergency room with fever and a rash for 3 or 4 days. And the serology was positive. Although the chest X-ray was normal, the patient did have basal pneumonia. Now, a perifollicular eruption would occur around hair follicles, and this is how they're recognized. Here's an example of a perifollicular eruption occurring in a COVID positive patient. And here another example of a perifollicular eruption. And these are follicular lesions occurring in a COVID positive patient. So the difference is that the follicular lesions will occur in the hair follicles, the perifollicular lesions will occur around the hair follicles, and the non-follicular ones will occur between hair follicles. Now here we see a papular eruption that's not strictly limited to hair follicles. So we call this a papular eruption. This was a 44-year-old female who presented with a simultaneous onset of rash, fever, and flu-like symptoms. So the rash had developed at the same time as all the other symptoms. There was no history of any drug, and this rash healed spontaneously within 2 days. Now, this incidentally was the first report that we had from South Africa to the American Academy's registry. And we would encourage anyone finding any skin lesions associated with COVID to report it to the American Academy. It's a worldwide registry, and we'll go through how that is done in a few minutes. So remember that COVID manifestations can occur inside the mouth as well. So patients can get an enanthem just like we see a rash inside the mouth in measles. This can happen even with COVID. So it's always worthwhile if we're seeing COVID patients to open the mouth and have a look inside there. And ask about other mucosal membranes as well, because they can also be involved. Then in children came this report of pediatric multisystem inflammatory syndrome, potentially associated with COVID-19. And this was a Kawasaki-like disease that we were beginning to see. It presented with fever, Kawasaki disease-like symptoms, and shock and abdominal symptoms. Now, Kawasaki's disease that many may be familiar with, or maybe not, so maybe it's worthwhile just going through some of the features of this Kawasaki disease. So if you are seeing children, it's always a wise idea to examine the eyes, the lips, the tongue. You get a strawberry tongue, and you can get lymph node enlargement. You can have a rash on the palms and soles, and it can affect the fingertips and toes, and the strawberry tongue is shown at the bottom. The significance of this condition, of course, is that it can affect the heart. And for this reason, it becomes a very important situation to identify any issue with the heart. It can even result in aneurysms. There can be inflammation of the blood vessels and the coronary blood vessels apart from the aneurysms. So here's an example that was published recently. This was published in the AAD journal on the 2nd of April this year. And this is a child with this multisystem inflammatory syndrome. So what about drugs associated with the COVID eruption? Are you able to hear me clearly there, or do we need to speak louder?
Your audio is fine. Please proceed. Thank you.
Right. So the drug eruptions associated with COVID-19, of course, many drugs are used these days, and any drug can cause a reaction. And this was from amoxicillin and ibuprofen and metamizole. And this happened 3 days after the patient presented with cough and fever. No, sorry, this patient presented with a 3-week history of cough and fever, and this rash developed 3 days after the drugs. It's in that order. So my apologies. Right, the patient was COVID positive, and just brings to mind the potential for drugs to trigger off quite severe eruptions. And this was a patient with bullous vasculitis and purpura fulminans in a patient who was confirmed to have COVID. Now, these kind of purpuric eruptions and lividoid eruptions can be quite severe, and they imply that there's severe microvascular injury that's mediated by complement, and it's associated with a procoagulant state, and it usually carries an ominous prognosis, but we need to keep an eye out for them. And this is purpura in a patient with COVID. Then there's this condition called acute generalized exanthematous pustular dermatosis, or AGEP. And this is a patient who presented with these features after hydroxychloroquine. So this was induced by hydroxychloroquine. Although we do see this condition called AGEP with other drugs. And this is one of my patients pre-COVID that we had with AGEP that didn't respond to just simply stopping the drugs. And this was from Ketek. And we eventually needed to put this patient on infliximab, a biologic drug that we use in psoriasis, and eventually brought this patient under control. And here's an example of a patient with Aegis and Bress syndrome, which is drug reaction with eosinophilia and systemic symptoms, also due to chloroquine. Now, what about occupational skin disease among healthcare workers during COVID? This was a publication from the JAB as well. They found that 70 or 97% of frontline healthcare workers had skin lesions. And a lot of them had it on the nasal bridge, but they also saw it on the hands and cheeks and forehead. And I think now with the passage of time, because this was an article from 2020, we are all now beginning to see patients who are developing rash from gloves and from masks and from headgear and all sorts of PPE. So we are seeing this from frequent hand washing. Although we are seeing it from masks, they found that goggles produce more damage than masks. And the risk factors for hand dermatitis included atopy, the winter season itself, low humidity, frequency of hand washing, the glove and the type of glove that is used, and the duration of employment. The partial solution is to use latex-free gloves. So we often ask them to use those blue nitrile gloves, and they tend to be better for those who have dermatitis of the hands. And the adhesive barrier films also prevent further damage. It's a good idea for them to take the gloves off every now and then, and to use a protective barrier, and to use lots of moisturizer after every use of the sanitizer. And some people can't tolerate the sanitizers at all, and they are asked to wash their hands with soap and water. Now here's some published examples of facial dermatitis. And this patient was using 60% ethanol directly on the skin 5 times daily. And here an example of hand dermatitis that's happening from excessive hand washing. And here's some contact dermatitis from PPE. Anna is going to show us some examples of hand dermatitis and various aspects of PPE dermatitis. So I'm going to just show only a few. And then there's the concept of mask acne or maskne. As you know, this is acne that corresponds to the area covered by masks. And we advise such patients to use non-comedogenic moisturizers and to take a break from makeup and to wash the fabric masks regularly, to remove the masks every now and then, and to dispose of them frequently and replace them. And then the acne, of course, is treated like we treat acne according to the grade of severity, and this will need topical medication and oral medication. And we, of course, need to look at other conditions that present like acne, like contact dermatitis, like rosacea, and they would be grouped under this condition. Now, again, to remind you, if anybody needs these posters, please feel free to give me a shout. Please send an email and I'll send this to you by return email. Right, then what about vaccine reactions? Nowadays, we've passed the stage where we are seeing only reactions from the condition itself and from the PPE. We are now beginning to see vaccine reactions as well. So local site reactions are common, but one can get urticaria from a vaccine. We may see morbilliform eruptions from a vaccine. There may be delayed local reactions and even erythema of the palms and soles. So if you are interested in reading this article on skin manifestations of COVID, a worldwide review, the reference appears below. And if you don't get a chance to take the reference down, I'd be happy to send you such reference as well. So this was a total of 1,211 patients. That gives you a pretty good sense of the kind of eruptions that are being seen throughout the world. Although I've tried here to summarize the most common eruptions that are seen throughout the world, including this country. And for those who are interested in looking at the cutaneous reactions to pharmacological agents, then there is this article that summarizes this in great, well, let's say it discusses these items in great detail. Right, so to summarize this aspect of clinical manifestations, we know that the dermatological manifestations are an evolving science. We don't know if there are any new manifestations with different different types of virus. Now we are seeing new variants of viruses emerging, although we know that there's no specific rash to COVID-19. So right now we are not seeing special eruptions with different variants. We are seeing the same kind of eruptions with all the variants of COVID. If there's COVID, then the manifestations are similar. So similar rashes also occur in other viral infections. So far there isn't any single type of manifestation that occurs exclusively with COVID. Some may even be coincidental and others may be due to drugs. And some rashes may be due to PPE. And it's unknown whether the presence of a rash or the type of rash has any influence on the course or the severity or even the prognosis of the disease. Although we know that some are associated now, we've discovered that some are associated with the clinical outcome. Now, just a few words about the AAD registry. This is Dr. Esther Freeman, who writes most of the articles regarding the American Academy Registry. I had the pleasure of participating in a webinar that was initiated in the United States on COVID, and these were the panelists on the right. And following this, we were invited to submit our own cases for the registry, which we did. And I showed you one of the cases that was sent initially, and subsequently we've sent other cases over. So we are actually participating in this registry as well. And I would like to invite doctors who are seeing skin conditions to please submit your cases to this American Academy Registry, because it just adds to the knowledge that we get. And of course, we will learn what to do with such individuals in such cases when we see them in future. So this was the spectrum of COVID-19. This was the initial publication, manifestations of an international registry of 700. The initial publication was 716 patients from 31 countries, and this would have been 30 without our contribution. And I was told that that was the only case initially that came from Africa, and I hope subsequently there were many other countries that contributed. And you can see South Africa in red in the whole continent. So we hope that there's going to be contributions from all over the world, so we can then derive useful information about how to treat patients with these skin conditions. Now, from this registry data, the most common manifestations were found to be morbilliform, perneo-like, urticaria, macular erythema, vesicular eruptions, papulosquamous eruptions, and retiform purpura. I think this table will make for some good questions later on. So we see that the most common manifestation are mobiliform in this series. Now from the registry data, we see that 12% developed skin eruptions prior to COVID. 8% of them were asymptomatic aside from the rash, and pernio-like lesions were associated with 19% of patients. So this is the web address of the American Academy Registry, the COVID registry. And the entry has to be made by healthcare professionals only. So if you have patients that are submitting data, the data will need to be entered by the healthcare professional that's looking after such a patient. Now it's very easy to enter the details. You go into the American Academy website, there are a whole lot of questions. It's just multiple tick forms. And if one puts a tick under a certain section, then sometimes a sub-menu opens up asking for a few more questions regarding that. And it's all very simple and very straightforward, and it's easy to fill in. And I think it's important that we fill this in to contribute to the worldwide amount of knowledge regarding this condition. So please report your cases if you see them. And if you need any help, and if you're not sure where to go, and if you need the address again, please just get in touch with me. I'd be happy to pass it on to you. Right, this was the statistics from last year, but of course now the numbers that they have in the registry are just increasing. And we were contemplating, of course, having our own registry. It takes a lot of work putting a registry together. We haven't got down to doing this yet in this country, at least for the skin. But at the moment, we are contributing to the registry I've just shown. And I'm sure if we have our own registry and then pictures are available for education of doctors and so on, and for better recognition of these conditions that become important manifestations of this condition, which allows for easier diagnosis. So please contribute to the registry that's available. Now, Ashraf, are we doing okay for time? Shall I continue and discuss how we are keeping the practice safe?
Please do. Thank you.
Right. Now, I thought we could share this information, and we'd be happy, very happy to hear from others who are listening, what they are doing in their practices that I haven't shown here for the benefit of everyone who's listening. So at the moment, we are doing telephonic screening for symptoms of COVID. In Westall Hospital, if patients have COVID, they go to a special COVID screening section of the hospital, and they are treated there for possible symptoms of COVID. We check for a history of contact. The patients are to arrive alone, unless, of course, the patient is a minor or an elderly individual, then only one relative is allowed. Now, the other relatives who come with the patients actually need to wait in the car, not in the waiting room, because the waiting room has to be reserved for a patient who's waiting to be seen. And of course, we try to keep the waiting room free, or at least with only 1 or 2 patients. And if as I mentioned, the other relatives wait in the car. Now, there are screening tools for those who need these screening tools about what kind of questions to ask. And these are available now on the net and on various apps. This place that you see, I'm not sure if the pointer works in this screen sharing, but I'm just pointing to the area below the life visual sign. And this area has been covered up, and this has become a screening station, and all patients pass through the screening point when they come into Westall Hospital. So now we have an electronic thermometer and a sanitization stand, and patients are then given a little form or a sticker so that they go just to the doctor that they are seeing, and then they exit the hospital. So this area here that cars used to go through to drop patients has now become a screening center in Westall Hospital. So temperatures are taken when patients arrive. They're checked for masks, and if they don't have it, one is provided to them. The staff are all in these shields, and we wear them as well when we practice, and these are provided at entrances, and either these or manual sanitizers are provided in every room in the practice as well. So patients are asked basic questions, and if they have any symptoms, they are referred. This is the entrance, the reception area in my own practice. So in those practices that don't have any screens, and these screens on the right-hand side are quite useful as a shield between the patients and the staff. We had put these windows when the practice had started just to maintain confidentiality when patients' details are discussed with other doctors and so on. So this has proven itself to good use because we can now close this. And I would sort of encourage the use of at least these kind of screens between the receptions, and I'm sure most people are doing this already anyway. And of course, excessive chairs have been removed. The practice looks like this now with absolutely no magazines and no brochures, which used to be stuck on the left-hand side. And there's no tea or coffee anymore. The tray sits empty because we're worried about spreading these viruses on these utensils. So everything is very bland, and patients come in, they get seen and they go, and nobody sits around. And there's various ways of social distancing. One can stick a little sticker on the chair, or one can put some tape around the chairs that are not being used if these chairs can't be moved out. But these are various strategies that we use to social distance the patients in the rooms. As I mentioned, no magazines, no toys, no tea, no coffee. And only one patient at a time in the rooms, and others wait in their cars. We have the sanitization ritual after each and every patient that comes to the practice. In other words, the doorknobs are cleaned with sanitizer. All surfaces that patients and doctors touch are cleaned up with sanitizer. The credit card machine is cleaned with sanitizer after every use and before every use. The beds are covered with plastic so that the plastic can be easily wiped down with sanitizer. And this is done after each and every patient. And some practices are using disposable paper that rolls up at the end, and they roll the paper out or roll it in. And that's another possibility. We spoke about the credit card machine already. Now, when we perform surgery, we stand now behind the patient if we're doing surgery of the head and not in front of the patient. The patients keep their masks on, and currently we're actually taping the mask onto the nose here and on the sides, and we leave the bottom open, and the procedure is carried out. We are wearing N95, and at the moment we are wearing N95, and on top of the N95 a surgical mask and the shield on top of that. And we are doing the procedures on the scalp or on the face, and as I said, if the face is being done, then we tape the mask onto the face. If we're doing one side of the face, we tape the mask onto the other side of the face. And patients then are shown a disclaimer or sign a disclaimer, and this was suggested by Dr. Michael Gold at the DAZZLE meeting, that whilst this practice takes every precaution to protect its patients from contracting coronavirus infection, the practice cannot guarantee that the infection cannot be acquired from the practice. I think it's a good idea to explain this to patients, because we are now hearing of doctors being accused of spreading virus to their patients. And to say that the practice accepts no liability for any patient for contracting coronavirus infection. And these are some of our contributors that have sent photographs that you had seen, so we are grateful to all of them. And I would like to, at this point, thank you for your attention. This is our web address, and this is our Instagram details, and the email address does not appear here, but just to remind you, it is raboobee@iafrica.com if you want those posters. So thank you very much. I'll hand you back to Ashraf, and thank you for your attention.
Thank you, Dr. Raboobee, for that wealth of information shared. My sense is we've got a few minutes left, and maybe at this point, I would want to go to some of the people who have raised questions for you specifically. In the question answer box, there is Wayne Fortuin and Anneke van Heerden and Malisela Nyamani. And so maybe one could start with, I think, Wayne Fortuin. I'm not sure if you can see your question answer box there on your side.
Yes, I can see. Wayne wants to know whether these occurrences were before or after vaccination. They were all before vaccination. All these manifestations were seen before vaccination, but I did show you a slide of the skin manifestations of vaccination. So remember that you can get skin eruptions from vaccination. And I think you'll recall that poster, which I showed about 5 different conditions. But all the ones that you are seeing over here, all before vaccination.
Okay,
I hope
thank
that
you.
answers your question.
Yeah, well, maybe if we have time at the end, we could potentially invite one or two of the questioners back.
Yeah.
And
In
then the
line
next
with the
question,
above,
yes.
in line with the above question, what are the possibilities for people with skin problems to develop similar types of rashes? In line with the above, what are the possibilities for people with skin problems to develop similar types of rashes? Sorry, I just need some clarifications. You mean somebody who's got atopic eczema, if it's possible for them to develop a rash more easily, if that's what you mean, then yes, sometimes that is so. We know that people with atopic dermatitis, for example, are prone to herpes virus infection, and they are prone to Kaposi's varicella eruption. So it is one of the aspects of skin manifestations of COVID is that it can worsen existing conditions. So the answer to this is yes, they can develop eruptions if they have existing skin problems.
Dr. Raboobee, just one moment. I can ask Wayne just to add something there. I've given him microphone rights. Can continue,
Right.
Wayne?
Hi, Doc. Thanks, Rafiq. Now, my question is based that in line with the above question was based, I put there after or before vaccination. Does this occur also after the vaccination or what? Thank you.
What we have seen is a rash from the vaccination. I'm not aware of reports of skin conditions in the literature where they've reported it after the patient has developed a vaccination. We know that patients develop COVID after vaccination, except it's not as severe. So probably the condition is not as severe, and the rashes are not being seen because of that. So theoretically, it is possible for them to develop it. If they, excuse me a second. Let me say that if a patient develops COVID, it is possible for that patient to develop a skin eruption. Even if this COVID develops after vaccination, it is possible because the patient is developing COVID. And 1 or 2% of patients who develop COVID develop skin manifestations.
Okay, Dr. Raboobee, Anneke van Heerden wants to know about the app. There was an address that was on your slides. Will we be sharing your slide packs with the attendees?
You've got this thing recorded, isn't it?
Yes, yes. Okay.
So well, we'll discuss whether the, excuse me. What I can do is send you the details, right? You can either email me directly for those details, or I'll send it to you and they can email you for the details. What would work out better?
So I will give Anneke your email address.
Yes, no problem. Give her my email address and I'll send her the details of that app.
Yes. And then Malisela is asking, I would like to be clarified on skin dermatitis that allegedly caused by frequent hand washing, as this is due to usage of water and soap or usage of alcohol-based sanitizers. Will you address this, or do we leave this for Anna?
Yes, well, Anna can also add to it. But this condition here, we see it mainly from the alcohol because it removes the fatty layers from the skin. And it's the alcohol that is causing more damage than the soap. We know that soap can also cause a problem. So one's got to use things like glycerine, soap, and so on if you have alcohol-based hand dermatitis. But Anna, I'd be happy for you to contribute and to add to that.
Thank you. And then it seems like Wayne has followed up on precautionary measures, doctors' surgeries and or practices. What are the level of contracting the virus? I would assume he's asking what's the risk of contracting the COVID-19 virus and in being infected within medical practices. Over to you, doctor.
We are exercising all these precautions not to pick up this infection. We have been working since May last year, and we have been exercising all these precautions every day from May last year, and we have not let our guard down in the practice. This is being practiced fully from day one, from the time we got back, from the time of the initial lockdown to now. And look, one never knows what's going to happen in the future, but until now, all the members of the practice have been safe. So I would like to think that these measures are working in the practice. And I know that those who are implementing these measures are keeping themselves safe. We never know where you pick this thing up from. It's not always from the practice that one picks it up, but my recommendation and suggestion is to please exercise these measures to keep yourself and your practices safe. I mean, one can pick it up from a supermarket, you can pick it up from people who travel in other modes of transport and come to your homes, you can pick it up from touching things, and we know how this virus spreads. But the main thing is at least to try and exercise all the precautions in the practice. I'm not sure if others have any other ideas to contribute or who know that they've exercised these measures and still picked it up. Please tell us about it when you're on the platform right now.
Thanks, Dr. Raboobee. Then there's the question by Joyce Lesiba, apologies. What is the implication to the employer for adverse reaction relating to vaccine administered in the workplace? Will this qualify as work-related? So I'm not sure if you want to touch on that. It's
I'm not in a position to answer. Maybe Anna, if you know the answer to this, you can talk about it.
Yeah, in essence, it's sort of a vaccination topic related question. And Joyce, we may just give you another email address for you to direct your particular question to. Rueda Johnson, how do we treat employees with contact dermatitis on the face due to masks, as it is compulsory to wear masks at work?
You could try a different mask for one thing. You need to find out what material has caused the problem. And masks are made of many different kinds of materials. You get them in fabric masks, you get cotton masks, you get silk masks, you get the masks that we wear as surgical masks, the N95. I think it will depend on what type of mask it is that's causing the problem, and maybe change that mask to a different type of mask. And the contact dermatitis itself will need to be treated with the appropriate measures. In other words, contact dermatitis will require the identification of the thing that's causing the contact dermatitis. And if you know the specific ingredient by doing a patch test, we do a patch test to find out what ingredient in the mask is causing a problem. And if we can identify that, then we look for a specific mask that doesn't contain that particular ingredient. Thank you.
Okay, so at the moment we about almost 5 minutes extra for this. We can get back to some of the other questions there after we've done with Anna's presentation. I'm sure that's okay with you, Dr. Raboobee?
Yeah. Please go ahead.
Okay, great. So thank you very much. That was Dr. Raboobee, dermatologist, dealing with the skin manifestations in patients with SARS-CoV-2 infection. Some of our questions have already started to go over to the aspect of chemical exposure to the skin, particularly cleansing agents and hand sanitizers, etc. And that topic is now going to be dealt with. That is skin reactions to COVID prevention measures, cleansing agents, and PPE, that's the masks and so on, and alternatives to reduce the impact. So I'm going to ask Anna just to share her presentation slides in the meantime. And by way of introduction, Anna Fourie is a colleague here at the NIOH and works as a senior medical scientist in the Immunology and Microbiology Section here at the NIOH National Institute for Occupational Health. She holds a master's degree in immunology and a postgraduate diploma in health sciences education. Her interest lies in allergy resulting from workplace exposure and occupational skin diseases. Anna has been involved in several studies in various workplaces looking at both skin and respiratory allergies, and has published various articles related to these, and assists with the teaching of both undergraduate and postgraduate students in occupational health and immunology with her colleagues. She has also run workshops on occupational allergic diseases in different provinces, and has run the occupational skin disease clinic here in the building at the NIH for over 22 years, and is responsible for the patch testing for occupational contact dermatitis. And with that introduction, thank you very much, Anna. I see that your slides are maximized and I can hear your microphone is open. So can we just test your audio?
Hi, Ashraf, can you hear me?
Yes, perfectly. I think you are close enough to your microphone. I'm handing over to you, Anna. Thank you very much.
Thank you, Ashraf, and good morning, everyone. So we are going to look at skin reaction to COVID preventative measures, and especially the cleansing agents and different forms of PPE. Okay, so we are going to look at COVID-19 and dermatitis from increased use of the cleansing agents and hand sanitizers. And just the increases of occupational skin diseases due to these cleansing agents and what is found in the literature out there. And once we've looked at that and seen the numbers, we'll look at the positive causative agents which can cause these problems and look at both the irritants and allergens that occur in agents that we use for skin cleansing. And then also the fact that poor hand care contributes quite proportionately to these problems. And then also briefly, we will look at the skin reactions due to the use of other protective measures. And I will concentrate mainly on gloves, masks, and respirators. So they say a picture paints 1,000 words. So I thought I would just flash up some pictures so that you can see these are cases that we have seen in our clinic, and due to different exposures in the workplace, wearing of gloves, etc. Maybe the use of cleaning agents as well. There's some irritant reactions. Contact urticaria can occur, and this is likely to have been from a cleanser or sanitizer that was being used. And then contact dermatitis, which is a delayed type of hypersensitivity from actually in this case gloves, and in this case a preservative in cleansers that are being used. So what is out there in the literature? Dr. Raboobee mentioned some of the numbers that we have seen from one in China, and these are just some of the cases, some of the studies that were done. And you can see there of course could be bias due to people that have actual problems reporting, but you can see 74% of people in this study of 542 people in the hospital reporting that they had reactions on their hands. Another study with 376 doctors and nurses in 5 hospitals, 84.6% showing dermatitis on their hands. Another study, 71% showing skin barrier damage. In an even bigger study, 10% of the people that reported actually had moisture-associated skin damage. Now, these are all self-reported, so one can expect a certain amount of bias. But these 2 studies were studies from the UK, one in South Wales, and then observational cases, a case series from a district hospital. And these are workers that reported to the clinic because of skin problems. And you can see that 62% of these cases were actually due to irritant hand dermatitis, and almost 24% had a worsening of pre-existing dermatological conditions. In 2 other clinics that were set up during COVID for workers to go to be assisted with their skin problems, again 35% in the one hospital and 48% in the other hospital had hand dermatitis. So you can see that hands are a very common feature of working in COVID preventative measures. So also decided to just take a very superficial look at the data from our clinic. And if I looked at an article that has not been published that we wrote, looking at patients over 10 years, almost 47% of these patients actually had hand dermatitis. So this is obviously pre-COVID. So it has been a reality out there for a long time. When we looked at the surveillance report that we produced in 2019, 28% of the patients that we saw actually had hands as their primary site of dermatitis. And of course, with COVID-19, with the increased frequency of hand cleansing, sanitizing, or hand washing for healthcare workers and in the general public, we felt that there was likely to result in an increase in the prevalence of hand dermatitis. And so I took a very superficial look at our data. There were only 37 patients seen because the clinic was closed for a while. And so these are patients that came to the clinic either to be seen by the dermatologist at our occupational skin disease clinic or for patch testing to determine whether there were allergies present. And 60% of these actually presented with hand dermatitis. And I think this is still the tip of the iceberg, because I've often walked around the corridors of our building and having people either show me or ask me about problems that they have experienced due to the new measures that have been put in place. So what are the substances that actually cause these problems? So the skin irritants include excessive use of water and soap, which of course are highly recommended protective measures against exposure to the virus. Exaggerated hand washing with the disinfectants, especially in the healthcare setting. And these substances can break down the barrier, allow for the penetration of foreign substances and the development of not only irritant dermatitis, but also allergic contact dermatitis from these substances, stimulating an immune response. It also results in a change in the normal microbial flora in or on the skin, and then there is an overgrowth of pathological organisms in the skin and infection. So even mild soaps containing alkyl sulfates, such as sodium lauryl sulfate, as a major surfactant, can be highly irritating. And for this reason, these have often been substituted with a more mild surfactants, such as lauryl glucoside and cocamidopropyl betaine. And these are thought to be better on the skin. But these surfactant residues in soap can form a reservoir on the skin, even after rinsing with water, if this is not completely sufficient and done extensively. And these small amounts that stay on the skin can actually produce a barrier impairment. The fact that I was not aware of was the use of hot water can enhance the irritant effects by promoting greater absorption of the cleansers. So it is advised that warm water is used when one is washing one's hands. Other irritants that are present in hand washing agents can include chlorhexidine digluconate, which is a very common antimicrobial agent used in cleaning substances used in hospitals. And chloroxylenol is another, and triclosan also can all be irritating. And then, as mentioned by Dr. Raboobee, alcohol-based hand sanitizers can also cause irritation and is probably being seen a lot. But I also want to fight for these sanitizers. And I will show you in successive slides the literature that I have picked up during the preparation of different talks that I have given. So irritant contact dermatitis is definitely the most common reaction that occurs to hand cleansers and sanitizers, but allergic reactions are still very possible. And some of the common allergens include quaternary ammonium compounds such as benzalkonium chloride and cetiramide, iodine or iodophores, betadine type cleansers that are used in hospitals, chlorhexidine, also a very common antimicrobial agent used for cleansing. And although I have tested for contact dermatitis to this, I have never had a positive reaction, but there is literature showing that it could be a type 1 immediate type of reaction to this agent. And there are other allergens as well. I mentioned that the triclosan and the chloroxylenol can be irritants, but they can also be allergenic. Very rarely has alcohol shown to be an allergen. More allergens, fragrances, surfactants and preservatives can all result in allergy. And certainly when we analyze our data from our clinic, fragrances are amongst the top allergens that are the cause of allergic reactions. And if one just thinks of the products we use and the amount of fragrance that are in these products, it's not really surprising that they can be problematic. So this is a list. I'm not going to go through them except to mention my favorite hobby horse is the methylchloroisothiazolanon and the methylisothiazolanon, which is a preservative we are seeing quite often in the clinic. And in fact, in cases more recently, the methyldibromoglutaronitrile is also a common preservative that is coming up positive in our patch testing. So as I said, some of our most common preservatives that we find. So our most common allergen is nickel, and that is common throughout the world. But in terms of preservatives, VMI, methylisothiazolanon, and the mix containing that substance, that preservative, are very common causes. And not only are they causes in soaps and self-care products and home care products, but also in the work environment. If there are, for example, cooling fluids used, this may be used in those fluids. And as I said, of recent, I have been seeing more reactions to the methyldibromoglutaronitrile. And then the fragrances, we have several different fragrances, and the mixes are the agents that come up more frequently, although people also react to balsam of Peru and sesquiterpene lactone. If you see these pictures, you see why it is one of my hobby horses. This patient was allergic to this preservative, and it was thought that it was possibly present in a glue that they were using to stick boxes. They were putting boxes together in the company, and may have been in the glues that were being used. And this patient, there were coolants used in the company, and this preservative was being added. And the problem here is that it is probably highly concentrated, and he may be exposed to the concentrated forms of the allergen. The problem is that once he goes out of the workplace, he is now sensitive to this in any of the cosmetics or self-care products that he uses. And other factors that can aggravate the skin. Certain hand hygiene practices that we perform all the time can increase the risk of skin irritation and should be avoided. For example, washing the hands with soap and water immediately before or after using the alcohol-based products. This is unnecessary. Both are adequate to do the cleansing, and it is unnecessary, and it removes the natural sebum layer that protects the skin and allows it to become dry and irritated with time. And also this can reduce the bactericidal efficacy of the skin barrier. So either one or the other is what should be used. Still other factors, the donning of gloves while the hands are still wet from either the washing or the applying of alcohol can just exacerbate the effect of these agents once they are against the skin, and they might be sweating inside the gloves and added a bit of friction, and this will increase the damage that occurs due to the wearing of gloves. Also, the wearing of gloves can cause skin irritation, and in fact, in many of the studies from Wuhan in China, it was shown that wearing gloves for very long periods of time per day and over periods of time in terms of months actually exacerbate the development of irritant dermatitis. Also, the number of times and when hands are washed. Now, the guidelines from the CDC and from other countries say that there should be 5 instances during patient care, but of course now with COVID, even outside the workplace, there are many occasions that one needs to sanitize, And this just enhances the breakdown of the skin barrier. And very importantly also, a lack of a good hand care regime. So now, after what Dr. Raboobee said, I'm a little, I feel I need to defend my stance here. And although the alcohol-based hand antiseptics can cause skin dryness and skin irritation, they are very effective in reducing the bacterial count on the hands. And many of the articles I've read say that they are tolerated better than the use of soap and water, since they are gentler on the skin, gentler on the skin than frequent soap and water washes. So it is being suggested as a preferable hand hygiene measure when the hands are not visibly soiled. Of course, if there is dirt on the hands, it is important that this be removed with soap and water. An added advantage, of course, of the antiseptics is the alcohol antiseptics is that they require less time than hand washing. They are often more accessible. I mean, one sees that now in every shopping center. You can put them at any place in the ward, in our consulting rooms, in the corridors of the buildings, etc. So they are much more accessible and therefore can be used more easily. And they're also self-drying, as even the drying process when one washes one's hands can be damaging to the barrier. If one uses, for example, rough paper towel and rubs the skin in order to ensure that there is a complete drying of the hands, this can lead to irritation. The thing with hand sanitizers is it is important that they are good sanitizers and that they contain skin emollients. You've seen that here in our own department, where we had a particular hand sanitizer that was causing problems for almost all of us, in fact, and we have now changed this. We have a hand sanitizer with emollients, and I must say that is all I use, and my hands are absolutely fine, and I'm not the best at looking after them. So it is important that skin emollients are present in the hand sanitizers. In addition to the appropriate cleansing agents, I think something that is often neglected is that it is extremely important that there's good hand care. And I think possibly why the hand sanitizers are causing such problems out in the general public is that people use the sanitizers but don't increase their hand care. So the use of moisturizing products is absolutely essential to restore the ability of the stratum corneum, which is the outer layer of the skin and that which protects the underlying layers, is very important. And so it is able to absorb, retain, and redistribute water to keep it moist and keep the integrity of the barrier as it should be. And of course, they are recommended for treating dry skin and mild dermatitis. Another important fact of the moisturizing substances is that they must be acceptable to the users. And this was found that it was one of the biggest obstacles to people using the moisturizers was if they were too oily or the fragrance was not, unfragrance would be preferable. If they did have fragrances, these were not acceptable to the users, and this limited the use by the workers, for example. Also, if they are used, they should not be in tubs, as one would then dip one's hands in and could cause contamination. So they should be in tubes or have dispensers for these moisturizers. So hand care for workers and outside of the workplace. Healthcare workers should use water-based creams at work. And this is because the oil-based moisturizers may have a deleterious effect on the integrity of rubber gloves. So it should not be used in the workplace. Barrier creams, which are available, are occlusive and can protect in the industrial environment, often against some of the harsh chemicals that are used there, but they are not recommended for healthcare workers, especially since they're probably not protective against microorganisms, the very small microorganisms. So the efficacy of these products is equivocal, And also these barrier creams can affect the efficacy of the antiseptic agents which are used in the facilities. And on top of all of that, they may also contain sensitizers, which may then result in allergic reactions to these barrier creams. But once workers return home, and especially if if hands are very dry, it is important that ointments are used, and these are ointments that have a sort of 80% oil and 20% water, so they are not water, they are more oil than water-based. And as I said, especially when there's extremely dry skin and if there's mild dermatitis. Often Dr. Carmen, who worked in our clinic, used to recommend that, and I've heard this from other doctors as well, that ointment be applied at night. These very thick, greasy ointments be applied, especially at night, and then worn under either cotton or very loose plastic gloves, like the PVC gloves, the see-through PVC gloves that one finds. And this actually helps to replenish the barrier. So these measures are very important for workers to keep their hands healthy. Of course, there's then, as I mentioned, the repeated hand sanitizing at the malls or shops. And again, can't emphasize enough the importance of regular moisturizing. Of course, moisturizing after each hand sanitizing event is impossible, because if one goes in and out of shops, one is sanitizing each time. But certainly, as soon as possible after leaving the mall, it is important that moisturizers are added. And I think that might be the problem, is that people are not moisturizing to deflate the effects of the alcohol, which removes the fatty layer on the skin. Of course, once the barrier is damaged, it is really problematic, because putting alcohol on broken skin can burn quite dramatically. And in that case, it may be important when going to malls that insist on sanitizing, might be a solution to wear gloves. This was a quote I thought was so apt. Healthy skin is a prerequisite for effective hand hygiene, since open wounds and damaged cracked skin may impair thorough disinfection. And of course, less than thorough disinfection can result in spreading of this horrible virus that we are living with. So looking at the effect of other protective equipment, personal protective equipment. So the COVID-19 has certainly brought the focus on protecting oneself and others, which has obviously always been around, but this has certainly brought it to the fore. And protective measures can include using a surgical mask, and we mentioned cloth masks, although they are not considered as PPE, they are considered just as a protective measure. Goggles are often worn to protect the eyes. Sometimes face shields can be seen as adjunct PPE, as they help to prevent fluids and so forth getting close to the face. Of course, we have our respirators, our N95 and what's FFP2s. There are gloves, gowns, and coveralls, all used to protect workers from being infected with the virus. So these all help to protect, but they do change the environment of the body, and this can lead to adverse effects. So some of the reactions to PPE, the skin reactions I've already mentioned can be irritant dermatitis. Allergic reactions can occur due to the materials used. Acne can result from, for example, wearing masks, and we've had a few cases of this being reported. They can result in respiratory symptoms such as rhinitis, asthma, and allergies. And latex is a typical example of this type of allergic reaction. They also, of course, result in physical discomfort, especially if total coveralls will result in heat, which can lead to dehydration, headaches, and dizziness. There are, of course, also pressure injuries, and there are some really harsh pictures from the international data showing injuries from pressure injuries from different PPE, such as the masks, the respirators, and also from the goggles that are worn. And these, of course, can result in, can be in the bridge, on the bridge of the nose, on the forehead if one is wearing these face shields, behind the ears from the elastics or ties of the PPE that is used. Again, just some of the international literature, several papers from Hubei Wuhan, and you see that it was a similar study that I reported previously. They showed that 84% of people had lesions of the nasal bridge or of the cheeks, and 57% showed damage of on the forehead. In this study, 75% showed problems on their cheeks and the bridge, and I won't go through all of them, but you can see that the percentage of people reporting problems are quite extensive. This is a study from the first SARS pandemic, and they showed 35% of people reacting to the N95 masks. Again, the studies from the UK, and these, rather than self-reporting, are actually observational studies, and only 4% showed facial symptoms. And I think similarly in South Africa, we have not seen, and I've been asking the dermatologists if they have seen the severe damage due to pressure of the different types of PPE, and we certainly have not seen much of that. And worsening of pre-existing dermatological conditions was reported again in almost 24% of the people seen at this clinic. And at the other two clinics, facial dermatosis occurred very different numbers, 46% in one clinic and only 3.7% in the other clinic. So the numbers differ, but it is no doubt that these damage to the facial skin can occur. So, yeah, just again, some pictures. Irritant reactions from wearing gloves, and these are all patients that we have seen in our clinic. But not only is wearing gloves a problem, but also it is extremely important that the correct gloves are worn in the workplace. Here we have an instance where a guy was working in a factory where they were machining metals. There were coolants being used, and he wore leather gloves because to deal with the hot metals, they had to wear these. But of course, the cooling fluids could get straight through the gloves, and in that hot environment with lots of friction, because the gloves are not very tightly fitting, you would get this type of irritant reaction occurring. In this case, the gloves were to the wrist, and the reaction occurred just above the gloves. And in this case, these vinyl gloves were being used by these workers. That was a pineapple processing plant. And of course, pineapples are very spiky, and you can see the water pouring out of these gloves. So these gloves were totally inappropriate. These workers were working in water all the time, and you can see the candida infections on the nails from happening. So not wearing the right gloves is very important, but reactions can still occur to the glove material. I have mentioned that allergies are not the most common reaction of the skin to these measures, but certainly we have seen them in our clinic. Allergic contact dermatitis, this person thought it was from the sanitizers because it had certainly come to the fore since using them. And although those might have contributed to this, this lady actually was reacting to thiuram, which is a antioxidant used in the manufacturing of gloves. And so it didn't matter whether she wore latex or nitrile gloves, both of them would have contained the thiuram. And in this sister, she's an interesting case, and I'm going to mention her on my next slide. So this is a sister from one of the hospitals. We investigated her. The first test that was done, because she had some respiratory symptoms, was to do a specific IgE to latex. And lo and behold, she was allergic to latex. So we suggested that she go back and they give her nitrile gloves. However, on doing patch testing, we actually identified that she was allergic to thiuram as well, which I mentioned is an antioxidant used in rubber gloves. And so giving her the latex did not actually solve the problem. But in addition to that, she was also allergic to fragrances and preservatives, and in fact nickel as well. So Dr. Raboobee mentioned that atopy may predispose to the development of skin conditions, and certainly is, they are more prone to irritants in the workplace. So this lady needed to be well dealt with, and in fact, I think this taught us several lessons. She was actually put onto a help desk and she was fine while she was there. They closed the help desk and then they put her back into the OPD, and apparently she wouldn't have had to wear gloves there, but she was doing blood pressures, and of course the bulb of the blood pressure cuff is made of rubber, and you can see the reaction, her finger, between her finger and her thumb and first finger. And so they didn't reduce the amount of exposure to rubber in the workplace, and she still had reactions. So when one is dealing with these cases, it is important to be thorough and to make sure that measures that are put in place to change the situation are actually effective. So the reaction to some of the facial protection measures, these are pictures from a study done in Italy, and is probably reactions to N95 respirators. And the problem with it is the long hours of wearing these. When the first wave happened in Italy, they were actually totally overrun, and these doctors were probably working very long hours. And this, of course, just exacerbates the damage. Obviously, the respirators were fitting very tightly, and so it is difficult to prevent this. But some of the measures that are being spoken about in the literature is the use of dressings, which can be either absorbent, hydrocolloidal, or just a barrier film. Then the difficulty with using these is that they cannot affect the protective fit of these respirators. Otherwise, we are exposing people to the virus. And another measure that is put forward is to limit the time of wearing. And of course, when the pandemic is at its highest, telling people to stop working after periods of time, of course, is quite difficult. Dr. Raboobee also mentioned the possibility of trying different types of masks in order to reduce the pressure or change where the pressure points are. And of course, also, again, I come back to the fact that it is extremely important that good skincare measures be put into place and that emollients be used. And again, not just as the masks are being fitted or used, but an hour before the masks are to be worn. It's good to moisturize the skin. Allergic reactions, although less common than the irritant ones, do occur, and this is a very classic example of a reaction to a rubber elastic, which was present on a mask that this worker was using, and he was allergic to mercaptobenzothiazole, and you can see the patch test reactions there. So it certainly can occur and would cause an allergic contact dermatitis. The reactions to the masks, the development of acne or aggravation of acne, which is already present, is a very real problem. Some cases have been referred to the Occupational Skin Disease Clinic here at NIOH, And I think Dr. Raboobee mentioned the treatment. It is important that the skin is routinely cleaned and moisturized, but with non-occluding creams, which would just make the situation worse. And again, emollient should be used 1 hour before using the facial PPE, and of course limiting the time of wearing if that is possible. This is from an article, again from Italy, and it's device-related pressure ulcers. And you can see it occurs on the bridge of the nose, which is probably from the metal part to press the respirator on the nose, and possibly also to goggles that have been worn. We have not seen any of this at our clinic, and asking the dermatologists as well. They haven't seen such severe damage from the protective measures. But again, to limit this is using emollients such as petroleum jelly, which can lubricate and protect the skin from sweat, and also to try and substitute the PPE. So if goggles were being used, to then try and use face shields, or possibly alternate them in order to allow the skin to rest from the damage that is occurring. Again, just a few quotes from different articles. Skin barrier dysfunction and potential microbiota disorders. So, in other words, if there are disorders already present, it might make the patients more vulnerable to mask side effects. So, prior damage or prior, for example, acne or atopy can affect people and make them more susceptible to damage from the measures that need to be used. But they can also result in high mask incompliance because of the discomfort, and this then could cause transmission of the pathogens. So looking after the skin and making sure that things are seen to as soon as problems start can certainly assist to ensure the efficacy of the measures that are put in place in workplaces. Mild abrasions of the face may increase the likelihood of face touching while not using PPE, or inadvertent PPE protocol breaches. And again, this will just result in transmission of the virus and in disease. Another which I really like is protection of the hands is a 24-hour, 7-day-a-week commitment. So some other considerations that should be taken to prevent adverse reactions. One should ensure that the PPE should fit properly. So if gloves are too tight, for example, the dexterity would be limited. They could tear during use and then result in transmission of infection. They would also cause pressure. They would restrict the blood flow to the fingers, and it would result in increased perspiration. So it is important that gloves fit correctly. On the other hand, if the gloves would be too loose, they will do a poor job of keeping out potential pathogens and could get caught in processes used and equipment being used when one is wearing the gloves. So very important that it fit properly. If respirators are not properly fitted, they cause damage to the skin, as seen in the pictures that showed from articles from overseas. If they are too loose, they would then also not protect against the infections. Also, the PPE must be appropriate for exposures. So for example, in a hospital environment, it would not be necessary for people to wear N95s if they were working in admin or in places where there is not high exposure to infected individuals, and that the people that wear the N95s when they are working in high-risk areas should be removed as soon as as they moved out of those areas. And still other facts that can be considered. It's important that the PPE that is being used provides protection for the required amount of time. Gloves have a breakthrough time for different chemicals. Substances can permeate through gloves, and they can degrade the glove material, And so one needs to make sure that these measures are seen to when gloves are being used. And normally gloves do have breakthrough times for different substances, but one must be aware that there is a mixture of chemicals in the workplace, and that they could then, these mixtures could result in breaking down of the gloves. Also, one must be aware of contaminants that occur, which may affect integrity of the gloves. For example, taken in an industrial setting where they are machining metals, the metal, little parts of metal can get into the liquids, and these can then penetrate through the gloves and damage them. And very importantly, often in the workplace, the companies will look at getting the cheapest PPE, but when one considers the cost of occupational skin disease, one could realize that getting good quality PPE is actually the cheaper alternative, because once occupational skin disease happens, there's treatment that has to occur. People take time off work to heal from their conditions. They could lose their jobs and may need to retrain to do some other kind of job. And this all is a huge cost. So it is important that companies consider that when they are buying or getting PPE for the workplace. And even more considerations, there needs to be very good education and training material available to ensure the proper use and care of all PPE, to try and limit the damage that they can cause and to ensure that they work properly. And a knowledge of exposures in the workplace is also essential, so that people know how to deal with substances they're working with and the dangers that are relevant to their workplace. There needs to also be an awareness of early symptoms of skin problems, so that these can be dealt with ASAP and prevent permanent damage from occurring. We need also to be aware that good housekeeping, good work practices, and self-care is very, very important in order to limit the effects of all these workplace exposures. So to end, the use of PPE can provide very necessary protection, but it can also cause adverse health reactions, and all possible measures need to be put in place in different workplaces to prevent the damage which can occur from these, from the use of these substances or materials. Thank you.
Thank you very much. That was N Fourie dealing with skin reactions for skin reactions to COVID prevention measures, preventative measures. That's including the chemicals like cleansing agents and PPE, which is the gloves, etc., goggles, masks, etc., and alternatives to reduce the impact. Thank you very much for that. So, Anna, I see that we have one hand raised. It's Johanna Glodina Kuhn. And I'm wondering if Johanna wanted to ask a question of you. In the meantime, we also have some questions we perhaps just want to deal with in the question answer box first. Anna, is that okay with you?
That's fine.
Okay, so I'm not sure. This very first question that was asked by Malisela, I would like to be clarified on skin dermatitis that allegedly caused by frequent hand washing. Is this due to usage of water and soap or usage of alcohol-based sanitizers? And you probably covered this in the presentation, but if you can just touch on Malisela's one.
Okay. Well, I actually would ask Dr. Raboobee also to add to that, if he's still connected. From all the literature I'm reading, they say that the hand sanitizers are less damaging than the use of soap and water, especially in the healthcare setting where they are antiseptics, and these can be damaging to the skin. But the common perception is that it is from the hand sanitizers. I think it's from lack of hand care. So very, very importantly, it's important that people use moisturizers to limit the effects of these sanitizers, or these hand cleaning techniques.
Dr. Raboobee, go
I
ahead.
agree.
Yes.
Yeah, I agree with you fully, Anna. Thank you very much for enumerating in such great detail the different aspects of the sanitizer and the soaps and the actual chemicals that are involved in there and how we go about determining what causes an allergic reaction. And I'm in full agreement with you that the hand sanitizer is the best way of cleaning the hands. The kind of patients I was referring to are those that have very severe atopic eczema. The moment you put hand sanitizer on them, they burn like crazy. They cannot tolerate it. It's only those that we advocate other methods of washing. If a hand sanitizer can be tolerated, then of course you get rapid elimination of the bacteria, the virus on the hands. So I would agree with that. If the patients develop an eczema, then we've got to treat the eczema. Sometimes we even have to use a bit of cortisone cream on those patients with the eczema. Sometimes they have no option. They even react to soaps. Remember that soaps are not substances that can't cause allergic reaction. Anna enumerated the substances in soap, all the fragrances and all the chemicals, the formaldehyde and so on that go in soaps. It can also cause a problem. The point is, we need to determine what aspect of the cleansing routine is actually causing the problem. And that helps us to determine what we actually need to use to clean the hands. So the normal ritual of hand sanitizing needs to go on. If the patients can't tolerate it, we find substitutes for them. And if they get very dry after using the hand sanitizers, they may use a moisturizer afterwards. Thank you.
Thanks, Doctor. So I know Wayne is asking some more questions there about chances of patients with chronic medications such as asthma and hypothyroidism. I'm pronouncing that correctly. Doctor, you just want to touch on that quickly?
Dwayne, what do you want to know? Whether those conditions can cause a rash or whether it's going to interfere with whether they can catch COVID more easily or whether it makes a difference to how we treat the rash? I'm not sure what you're asking there.
So whilst we wait just to activate Wayne, where is it now? Okay, there we go. So Wayne, do you just want to open your microphone and just touch on all your questions? I want to move over to the other hand that was actually raised a moment ago, and that was Johanna's. Wayne, go ahead.
Yeah, thank you, Ashraf. Doc, it's in terms of my question for where people are not talking or announcing that. I mean, this is something different from AIDS. But here, if you are in close contact, you don't have to have any direct social contact with the patient or person that's COVID positive. You touch, for example, services they've touched previously before you. Now, it's on that basis that people are scared or they keep quiet and not alerting other people, you understand? And that leads to a fear situation. And in terms of the law says it's criminal for you to keep quiet, knowing that you had it and you didn't open up also. What are the safeguarding around that?
Thanks,
Without
Wayne.
mentioning a person.
I wrote a little answer for you there about the fact that we need to educate people about the fact that there's no stigma around this condition, and they need to actually learn to speak about it because it's not going to give them any negative impression in the society. Is your question about stigmatization around this condition? That people believe they're going to be stigmatized if they're going to talk about it? I think the only way around that. The only way around that is to encourage as many people as possible to talk about the condition so people realize that there is no stigma around it, that they can talk about it, that they can share the information about it, and people will benefit if they do share about it. I know that we've had this app
thanks,
that the government
Wayne.
was announcing at one stage, but nobody puts themselves on the
my other
app.
question.
Wayne, I can't give you another bite at the apple. You'll have to wait. Thank you very much. Just
sorry,
hold on.
it
Wayne,
was for the medication.
Wayne, can I pause you? Thank you. So could I ask Joanna just to open your microphone, Joanna Kun, and if you could ask your question. You must just unmute your microphone, Joanna. Okay, I'm not sure if Joanna's still trying to figure out that. With regard to Veronica, early last year, we learned that sanitizer takes 60 seconds to kill COVID. Joanna, I just saw your microphone unmute. You want to proceed? Okay, waiting for Joanna again. So, Veronica, yes, we can. Please,
Yes,
if you can
sorry,
proceed.
sorry. Yeah, did I disturb because a client was phoning me? So sorry about that.
No,
Yeah,
go ahead. Do you have a question? Please proceed.
no, I do not have a question, and I couldn't follow anything or everything. Yeah, our days is a little bit busy, so I will listen afterwards to the whole
Okay.
recording again. I
Great.
think it will be better for me to listen to everything again.
Thanks. So if you could just lower your hand, you've raised your hand there. Thanks for that. So back to Veronica. So back to Veronica's question. Early last year, we learned that sanitizer takes 60 seconds to kill COVID, where the soap and water only takes 20 seconds. Is this not true? So maybe first to you, Doc, and then to Anna, if she wants to add something.
I think if you don't mind, I'm going to ask Anna if she can handle this question.
Anna, please go ahead.
From the literature I've been looking at, it's actually the opposite way around, where alcohol actually kills them more quickly. Certainly they recommend 30-second wipe with the alcohol. So yes, that's my answer. Doc?
Thanks for that, Anna.
Thanks,
I mean, if
in agreement with that, Anna.
Great, thank you very much. So if that person wants to follow up with anything else, I'll certainly encourage to email us at info.
Also, if I could just add to Anna's comment.
Go ahead.
We are following a certain procedure in washing the hands with soap and water. So as long as they are following that procedure of washing the front of the hands and then the backs of the hands and between the fingers and then the tips of the fingers and so on, and that will increase the rate of killing of any organism that's there. And if we just casually take this thing and do 20 seconds of wiping, probably it's not going to do the trick. So whatever system that we are using, we need to observe the proper method of washing. And those posters are everywhere about how to wash.
Yeah, and you encourage to sing, I think, happy birthday, is it twice? So yes, those are the basic precautionary measures, the basic preventative measures, and we must practice all of those, right?
Yeah.
Even if we've had the jab, practicing those measures are critical, given that different variants are still hanging around. Let me quickly go to Courage Koza. Are there ways for companies to know if a particular brand of PPE is prone to causing skin disease? Would they have to avoid brands that contain certain chemicals? Are there guidelines or standards for the companies to know what to avoid? And my sense is this is probably where the employer is acquiring and procuring the barriers and other sort of preventive measures, as well as, I guess, chemicals that people may use when they do their work. Anna, do you want to start off before I go to Doc?
Okay, so it is difficult to say that there's a particular brand. I think it is very important that risk assessments are done in different companies to assess what is the best type of PPE that is to be used to protect people against the chemicals that they are using in that particular workplace, to ensure that there is protection. So not particular brand, but particular type of PPE is very important.
Thanks. And just by way of comment, in a factory, if they discover that somebody is developing a rash, and if this becomes a trend and a pattern, then of course there's got to be widespread patch testing to find out whether that particular ingredient is affecting more people than just one. And I think often the only time we find out whether something is suitable or not is if it affects somebody. Then if there's something available that the rest of mankind uses without a problem, then that will be made available to all the factories. But by the same token, if you have an outbreak in a particular factory, maybe there's a high incidence of people not tolerating that particular substance, we've got to look for it at that particular time and find out what it is.
Thank you, Anna. Thank you.
For example, I once went into a factory that used to make car seats, and then they used to put warmers in the car seats to heat the seats up. and it was one of the big car manufacturers. Then they changed the substance, and they used a different fabric that had fine little needles in them that used to enter the skin and cause a contact dermatitis. And we traced it to that particular thing. So it was in that factory that it was changed. That particular thing was changed for a certain factory, and that's where they began seeing the problem. So sometimes it arises only after we see that outbreak.
Thank you, Dr. Raboobee. Then there is a question, Anna, based on the slides. What are your recommendations for hand sanitizer or soap with safest ingredients, especially at work where most of one's time are being spent? It sounds like a part of another question asked, Anna.
As the NIOH, we don't recommend particular cleansers or substances, but certainly I think if one is using substances and this is a problem, and a risk assessment needs to be done and to ensure that this can be changed.
Okay. Doc, you want to add something there?
No, well, we tell patients that the alcohol has to be at least 70%. And then as far as moisturizers are concerned, Anna very ably touched on the chemical substances in soap that can end up causing a problem. She mentioned lauryl sulfate and so on. So we generally ask them to use soaps that contain glycerine, and we find that that produces less allergic contact dermatitis than some of the other soaps that contain the ingredients that were mentioned by Anna earlier. I don't know, Anna, do you agree with that?
Definitely, yes.
Thank you.
This question, I think, is probably self-explanatory. Can one ask your employer for a cream or hand moisturizer? And quite clearly, I think, Anna, you've covered this. You can perhaps just maybe correct me if I'm wrong, that for the preventive measures, based on the risk assessment and the advice from experts, dermatological and others, there would be recommendations for what creams or moisturizers may be appropriate, and that the employer would need to provide that as a preventive measure, and if it's in response to an actual exposure and skin issue, it might be prescribed. Am I correct on that, Anna and Doc?
I think so, yes.
Yeah.
Okay, so I think we're on the last of our questions, and that brings us into a good space to close within the next minute or two. With regard to pressure on the face, one can remove the mask, or this is probably more with goggles, I think you were referring to earlier, and perhaps some masks, if you can only, so the question is, can one work without a mask if it's putting pressure on the face? And my assumption is that would be yes. I'm in an office alone here, and I'm in this office for most of the day alone, and only when colleagues enter do we then ensure there's social distancing and masks are worn, and obviously we do sanitize when we touch handles, etc. So I guess that's an obvious answer there as well. I don't know if you want to add something there, Doc and Anna.
Yeah, I think that question has been answered. Now, just one thing, that the N95 mask contains a metal strip across. And remember that how firmly you press a metal strip and how little space there is when you bend the metal strip will impact on what it does on the nose. And sometimes I find that when you bend the metal strip, if you hold a pencil there and then bend the metal strip, it at least creates a bit of a curvature where the metal strip goes, and that protects the nose. And the other thing is, one can stick on some silicone gel pad on the nose before placing the N95 mask on it. I wear an N95 mask the whole day, and I do that, and it protects my nose. In the beginning, I used to have a really tough time on my nose. It used to cause redness every day. It used to almost ulcerate the skin. And now that I'm putting some silicone gel on it and bending the metal with a slightly wider bend, you know, that's making a difference. So maybe that's an idea for others to exercise as well.
Thank you, Dr. Raboobee. I'm going to take that as your final general take-home recommendation, and I'm just going to offer Anna the last minute to offer any final comments and take-home message for our attendees before we close. Anna?
I can only again say, moisturize, 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 and look after your skin. We have to have these measures in place, and it's important that we have the correct processes in place to protect ourselves from damage that can occur from it. Thanks.
Thank you very much. And then, so thanks to, final comment from you, Doc? Are you okay?
I think examine the skin, examine the mouth. And if you find any rash, report it and add it to the registry. Thank you very much.
So be alert and don't just take care of your own health, observe and take care and support colleagues and support those professionals within the workplace or those who are contracted to your workplace to ensure that we deal with COVID-19 and all other biological hazards, and in particular also in this particular case, those that might affect our skin. Let us be preventative, and if something happens, let us consult the appropriate professionals to ensure that we recover as soon as possible. So thanks to you, Dr. Raboobee. There's been many thanks in the chat box as well for you and for Anna, and also N Fourie from the Immunology and Microbiology Section here at the NIOH. Thank you very much for both your contributions. It's been most insightful, as some colleagues, some attendees have indicated, and from Wayne Fortin saying very informative as well, I think before he departed, having kept us so busy. Okay, so, and then clearly from us also here to our IT team, in particular Tabani Zwane, who's been very patient with us, hoping that we would have actually ended earlier as per the program. And many thanks to him for sticking with us until the end. And that's it for this particular webinar on COVID-19 and skin conditions in the workplace, brought to you by the National Institute for Occupational Health, a specialized division of the National Health Laboratory Services. Thank you, goodbye, and we'll see you on our next webinar. The next webinar will be dealing with COVID-19 droplets versus aerosols and ventilation, the role of ventilation in the workplace. See you next week, Thursday. Goodbye.
Thanks to you too, Ashraf.
Thanks, Ashraf, and thanks, Dr. Raboobee.
Thanks, Anna. Thanks. Nice seeing you.
Pleasure. Goodbye.
Yes, good seeing you.
Thank you. Thank you. Bye. Bye.